first endoscopy session of 2024. I trust you've had a restful festive season and are renewed and invigorated for the new year. Again, this session is hosted via Project Echo in Mexico in association with the Gastric Foundation, and it goes by the name of G-Echo. This is a regular session. This is our endoscopy session, which is routinely held on a Wednesday, as are the other sessions. Just remember that we would like you to ask the speaker questions regarding the talk and to make it as interactive as possible. Today we're going to revisit a topic that was dealt with, I think, almost 18 months ago, because I think it's a very topical topic and one that trainees and experienced gastroenterologists need to have their fingers on, because they see it from time to time, but not every day. And it's my great pleasure to ask Galya Chinnery to do that, now Professor Chinnery, and that's based on our hard work in developing foregut surgery and interventional endoscopy for the foregut. So look forward to hearing what Professor Chinnery has to say about managing gastric polyps. Over to you, Galya.
Thanks, Prof. Let me just get the screen going. Sorry, one sec.
That's okay.
Sorry. A bit asleep today. Sorry, Prof. Give me a sec. There we go. All right. Please just confirm someone that that's visible.
Yes, it is.
Thank you. So first of all, thank you for joining this afternoon. And as Prof said, we actually did this almost 2 years ago. And I'm going to disagree with one thing that Prof said, in that this gastric polyps are probably the most common reason for me to be called to the endoscopy suite by colleagues. What do we do with this polyp now? So the aim for today is to give you a very practical approach to them and hopefully leave you with an idea of how to identify the sort of more common ones. I mean, there's a host of them. I want you to walk away with an idea of confidently managing the more common ones. And it's not something to be worried about. They are pretty easily dealt with, but let's take you through it. And obviously, I welcome any questions at the end or in between. So the first thing to appreciate is I think they're pretty common. There are varying incidences reported from 0.5 up to 1/4 of endoscopies. Now, I think we're sort of sitting somewhere in between, in that there's a polyp or two on every endoscopy list that we do. So probably about 10%. And you'll all agree with me without a doubt that these three groups are the most common, and I want you to be able to identify them easily. Fundic gland polyps right on top, hyperplastic polyps in the middle, and then your adenomatous polyps, which we have to deal with in about 25% of cases. You'll agree with me also that clinical symptoms are very rare and mostly related to those polyps that are larger. And the most common thing that they would come with, I think, is an iron deficiency anemia. On the odd occasion, we've got someone who actually presents with a bleed, but it's never something torrential. And even more rarely, the patient that will come to you with an obstruction. And interestingly, that's usually an intermittent obstruction. And we'll talk about that just now. And I think, I must be honest, I've never seen someone coming with discomfort related to polyps. It's usually more an obstructive picture, but it is mentioned. So let's put it out there. As a starting point, I think fair for everybody, we need to be on the same page as regards describing these things, because you're not necessarily going to be the same person scoping that specific individual again. So do describe your polyps, have a way of writing down what they look like. We use the Paris classification, although this was, as you know, originally done for the colonic polyps, but describe your polyps. And then secondly, make sure that you let the next endoscopist know where you saw it. Very important to put a map of your polyps out there. And I think the other thing that's quite relevant is you can only map your polyps if you have a good idea of your endoscopic anatomy, if I can put it that way. So be very sure that you know where exactly you are. It can be confusing, especially when you've retroflexed to decide which is, sounds so easy, but to decide which is anterior and posterior greater curve isn't easy. So make sure you're getting that right. And the best position is looking from the top, then you don't get too confused. So I thought we'd start off with a few little videos. This is a 67-year-old lady referred to you on your elective list with an iron deficiency anemia. She's on chronic PPIs for reflux. And what you see on retroflexion specifically are tiny little polyps scattered throughout the gastric body and the fundus. So that's kind of what you normally would see when you are thinking of fundic gland polyps. Now, those are common up to a quarter of upper endoscopies. And what I want you to remember here is what they look like and who has them, because that's going to tell you what to do with them. Middle-aged females, usually the patients that present with them, they are small, these things, less than 5 millimeters usually. How do you judge size? We tend to, I think all of us, overestimate size endoscopically. It's not just a macroscopic image that you're getting. It's just a natural thing to do. There's not much to correlate size to. So if you really want an accurate size, get your biopsy forceps, open it. Depending on your size that you're using, they're about 5 to 6 millimeters when the jaws are open. And you can put it next to that, and then you get quite a nice idea of the diameter of the polyp you're looking at. Hyperplastic polyps, fundic gland polyps. They can be sessile, single. They can usually present multiple, as we said, body and fundus. Most of us can identify them, but you should, in my opinion, take a biopsy always to confirm. The nice thing about them that differentiates them from others is that they have usually a beautiful smooth lining to them. They are lighter, they're quite pretty in a way, and they're shiny. Compared to the rest of the surrounding mucosa, they are pale. And if you look quite close, and even if you use your NBI, a very refined look to them. There's nothing, they're just, I don't know, pretty looking polyps, if I can put it that way. Lacy, beautiful little blood vessels. Translucent is probably the word, not shiny. Microscopically, remember that they are consistent, they consist of fundic syntic glands. They are surrounded by, they are lined by normal gastric epithelium, and the surrounding mucosa around these polyps is usually normal. There isn't a gastritis or a metaplasia in the background. So importantly here, I think, remember that malignant potential in fundic gland polyps is extremely rare. Really it is. The low-grade dysplasia rate is less than 0.3%. The only time you get a little bit excited is potentially if they are larger than 10 millimeters. Remember, there is no association with H. pylori. The way I remember it is the middle-aged ladies are decent folk. They don't associate with H. pylori. So no association. What they do associate quite clearly with is chronic PPI use. What I want to mention in the same area here in your fundus, if you look up and you see an absolute carpet of large fundic, what you think are fundic gland polyps, be cautious. They don't usually make a carpet. You need to evaluate for a syndromic association. If there's really a huge amount, look out, please, for the gastric adenocarcinoma and proximal polyposis syndrome. I've put a picture up there. I'm going to be honest with you, I've not myself seen one of these, but this is a real gastric carcinoma risk, in that up to a quarter will progress to an adenocarcinoma. And it's one of the rare situations where you would offer your patient proximal prophylactic, prophylactic gastrectomy, and definitely consider sending that patient to a geneticist. Back to our fundic gland polyps. So what do you do with them? So confirm, first of all, with your endoscopic suspicion. I would always biopsy. You want to exclude dysplasia. I suppose that risk is only, although there when it's bigger than 10 millimeters. But to me, I think any patient that knows they've got polyps will want that reassurance. So I always biopsy at least once, and then once you've confirmed, well, then that's good. Then the literature will suggest to you to discontinue PPIs. I'm not sure I would do that, in that the vast majority of patients on a chronic PPI are doing well with their PPIs, and they're there for a reason. I don't necessarily disagree with that. I don't think they're doing any harm, and the malignant potential, as we said, is teeny weeny. Yeah, I think that's a personal preference if you're going to go that route. All polyps, you should exclude pre-neoplasia and H. pylori of the surrounding mucosa, so do biopsy it. But remember, the middle-aged lady, she's a decent lass. She does not associate generally with H. pylori. So this is my slide for you to remember fundic gland polyps. If you Google middle-aged lady images, that's what comes up. And what you see there is they've all got a very similar haircut, and they all sort of crop at the neck, pretty much like the little polyps themselves. They have this little cropped look to them. Alternatively, you can imagine them like jellyfish that have washed up on the beach. And then, of course, as we said, remember, definitely a PPI association. So that's my story on fundic gland polyps. Here's another little video. This is a chap in his mid-50s, and he's been also sent to you from your colleagues for an iron deficiency anemia. And when you go down, you see these couple of isolated polyps, one slightly larger sitting there on the incisura. And when you go closer with your NBI, quite a vascular appearance, but nothing irregular about those vessels. And quite clearly a little sluffy fibrinous top to some of them. And that's kind of the giveaway, in my opinion. Hyperplastic polyps look like angry mushrooms. They've often got a stalk. They are often having a whitish inflammatory fibrin spot or spots on the top. And you can imagine with that little stalk and that rough surface, when they wave around, that you can potentially, if it's a large enough one, present over time with a bit of an iron deficiency anemia. Here are some other images just for you to see. You can have isolated hyperplastic polyps, and then of course you can have a multitude thereof, and they're not only associated with the antrum, but that's usually where you find them. As I said, often with a stalk, but not always. What is quite nice about them compared to the fundic gland polyps, which were pale, translucent almost, as we said, these hyperplastic polyps, even if they don't have that classic mushroom with a fibrin on top look, they are very red and vascular when you go close up. So that's quite that prominent vasculature is quite clear, and I think differentiates them very easily from the fundic gland polyps. So what do you do about them? So first of all, If they are, this is not my video, this is a video of a multitude of antral and gastric body hyperplastic polyps. And you can see the endoscopist having fun, going wild and just chopping them all off, as many as he or she can. For me, again, you need to diagnose them and deal with the underlying problem. You must take them out if they are large. And this is something that frequently presents as quite a large polyp, and up to a third will be bigger than 10 millimeters. These ones are usually single, often in the antrum, and we see them quite close to the pyloric channel for some reason. That's just anecdotally. And if they're multiple, then they can definitely be throughout the stomach, but they are heavier, more dominant towards the antrum. Definitely an H. pylori association, either current infection or previous infection. And you can get some degree of regression should you have a successful eradication thereof. Again, really symptomatic unless they are large, and that's, as we said, for that giant sort of waving fibrinous top, you can imagine why. What you need to biopsy is not just the polyp in this case, it is most definitely also the surrounding mucosa. I'd like to show you one here that is presenting very large and solitary, a single one down on the pyloric inlet. And what you can see here is that it's intersuscepting periodically in and out, waving like a frond. Beautiful stalk. And you do get the impression that it's a kind of an irregular surface, but it doesn't have that classic sort of fibrinous spot, mushroomy look. But a lovely stalk, and that's going to get all of us salivating. This is another one that we did some time ago. And again, this is interesting in that, remember in the beginning, we spoke about patients presenting with intermittent obstruction. And this is what happens. You get this intersusception in and out through the pylorus of these polyps that sit close to the channel, or more importantly, the ones that are in the intersutura. Those are the ones that get pulled and stuck. Fortunately, hyperplastic polyps are quite soft and friable, and usually pass in and out quite easily. But the more solid polyps we'll get to later can be a problem. A little bit more about hyperplastic polyps. Do remember, as we said, the angry mushroom, there's definitely an inflammatory component here. And there's a lot of regeneration happening there. And if you go and look at it microscopically, there's a hyperproliferation of mucin-producing foveolar cells and a mixed inflammatory cell infiltrate. What to do? Here, I think the big thing is to remember, yes, there is a malignant potential. Although there's an inflammatory background, here you need to watch out. It's low, but it definitely is a real risk. The majority of those presenting with dysplasia will fortunately have something that we're not too worried about, an intestinal metaplasia, and then you'll get a handful having a focal dysplasia. We have definitely plucked a few out where there's been an unsuspected adenocarcinoma, and that is again always increasing in risk as the size of your hyperplastic polyp increases. So that's important. Size makes a difference here. Interestingly and importantly, I think this is something we forget. We get so excited about the giant big polyp that we do forget to biopsy the surrounding mucosa, in that the risk of mucosal degeneration and dysplasia developing is higher in the surrounding mucosa of a hyperplastic polyp than the polyp itself. So I've done it often, got excited, done the polyp and forgotten to biopsy the surrounding mucosa. So that's something you'd have to go back and do. So remember that, always biopsy with a hyperplastic polyp your surrounding mucosa, even more so important than with the Fundic glands. So just to summarize, if they're symptomatic with iron deficiency anemia, or big, or you're concerned about the appearance with size and dysplasia, please take it out. If there are single or few of them, remove one, and you can repeat the scope in a year to ensure no concerning recurrences in size. But generally, if they're small, you can leave them alone, less than 10 millimeters, but you do need to eradicate for H. pylori if this is present on your biopsies of the surrounding mucosa, and you should repeat the scope in a year. And we mentioned already that you're looking for pre-neoplastic conditions of the mucosa. Here's that same polyp that I showed you in the beginning, single solitary pyloric channel polyp. Came back on initial biopsy of the tip, just hyperplastic, and then we went back and decided, fantastic, let's take it out. We injected here, we use methylene blue with a touch of adrenaline in it. Got the snare across nicely, and it had such a beautiful, easy stalk to snare off. So I think you'll agree that's quite an easy one to get. And you'll see shortly that we had no bleeding. That surface there, as you pull it, you can see it is a bit more friable than a Fundic gland polyp would be. And then the final aspect was obviously to get it out and sent off for histology. The reason I'm showing you this one again is that this one came back with an adenocarcinoma. And we had a positive margin in the stalk. We went back and did an EMR on the stalk, and then that came back clear. So to me, this was a bit unexpected. Size obviously was a warning, but looked otherwise pretty good. So that was a malignant one. So just to summarize, hyperplastic polyps, 3 images to remember them by: red angry mushroom, that fibrinous exudate sitting on top. They're friable, they'll bleed, and remember that they have a malignant association, and definitely a malignant association of the surrounding mucosa and a strong association with H. pylori. There are a few sub-entities, and specifically what I'd like to mention to you here are portal hypertensive gastric polyps. Now, if you look at them quickly, they look pretty much like hyperplastic polyps. And I mention them here in that I am not sure how aggressively I would manage them personally. We've tried once, and I'll show you why not again. They are, if you compare to normal hyperplastic polyps, slightly larger, more numerous, and if you go close with the NBI, the vascularity is quite impressive, as you can imagine, with a background of portal hypertension. The clinical course, if you read up on them, pretty much unknown. They do seem to regress, obviously, makes sense with the treatment of the portal hypertension that's in the background. The recommendations are such that you should remove them if they're bigger than 10 millimeters, but that's a bit tricky in that they often are bigger than that. They actually can get quite large, 20 to 30 millimeters. You may see them sporadically, but the ones we've come across have been multiple, and they're definitely situated in the antrum. From our side, the body is obviously reported as well, but we've seen them mainly in the antrum. And if you're not treating the portal hypertension, they will obviously come back should you decide to remove them. I've put 2 images next to each other here. On the left, nice, happy, normal hyperplastic polyps with a nice little stalk. Not really a fibrinous exudate, but anyway, that's a hyperplastic. And then on the right, just to compare portal hypertensive gastric polyps, you can see they are more situated in the antrum, much larger. And if you go close, very vascular. And this is the important slide. That's the difference when you take them out. So on the left, a nice, easy, simple hyperplastic polypectomy, no bleeding from the stalk. By comparison, on the other side, 1 polyp removed and 5 or 6 clips later and a lot of sweating later. So these things are super vascular. So just snaring it is not going to end happily. And you do need to be prepared for quite an outing when you take these out. So approach them, if I can say, with some caution should you want to just biopsy them. I think you might get away with it. again, that will bleed too. The third big group, which I'd like to chat about, obviously adenomatous polyps. Now, they may be incidental, sporadic, or of course associated with syndromic patients, usually towards the 6th or 7th decades, but that's not exclusively so. And usually they are very nicely well demarcated lesions that are quite clear to see. There's absolutely no doubt, they are neoplastic precursors of adenocele. They, as I said, more often in the antrum. They follow non-cardiac gastric CA epidemiology. So this is a pre-neoplastic lesion that absolutely it's inexcusable not to remove. So if you're not happy with doing that, please refer on. The one thing that I sometimes, this is a picture not of mine, but does help. You don't, although I said they're nicely demarcated, sometimes not so well as regards the edge. And you can see here, this isn't as nice as that first image. So putting some sort of endoscopic dye, whatever you've got available to demarcate better, can assist you with your endoscopic resection. So that's a trick to use. Fortunately, most of the time, you will see them more as an exophytic type, excuse me, type of growth. The background histology that you're going to get back is similar to your colonic polyps. There's going to be an element of tubular villus or tubular villus on your report. They are neoplastic, as we said, and the comparison here as regards your surrounding mucosa, it will be normal, not pre-neoplastic, as with your hyperplastic polyps. For me, you may disagree, but to me, I find they look a little bit like a brain that's been stepped on the sidewalk. A little bit disorganized compared to the nice normal brain pattern, but I think there's something about that looks similar, and I remember a brain as being an adenomatous polyp. Just for me, you might disagree completely. So either flat, sessile, they vary in size. They are not often more than 20 millimeters in diameter. Very seldom any bigger than that. No H. pylori association, but yes, as regards malignant risk. The size makes a big difference there, increasing with size. And if you have a villus component to your biopsies, then please be cautious. That thing must come out. Depending again on what literature you read, up to 60%, that's a lot, can be associated with synchronous gastric CA. And the proportion of neoplastic adenomatous polyps from that is by far the highest of the three in the group. So make an effort to get these out. There's no excuse, you can't leave it there. So resect irrespective of size. You can biopsy the normal mucosa, in that you do need to do that. That's part of the proper workup for gastric polyps, but you shouldn't find H. pylori, and you shouldn't find atrophic gastritis or anything like that. Do you do an EMR or an ESD? Well, that obviously depends on where it is, the size of it, and how comfortable you are. A lot of what you do is how comfortable you are and what you can do in your specific unit. And I think partially resecting them isn't the end of the world, as long as you are following them up and go back and complete your resection. And then to remember that even when you think you've done an absolutely fantastic job and taken the whole jolly thing out, up to 3% will come back. So once you've made the diagnosis of an adenoma and taken it out, that does not mean you end your liaison with that patient. That patient needs a scope again. Specifically, the guidelines are 6 months if there was any focus of high-grade dysplasia, or of course, if you've done an incomplete resection, you're going back. If not high-grade, then you can go back in a year's time. I'm showing you here, excuse me, a picture of a small adenoma in the junction between D1, D2. Here, D1, D2 polyps especially D2, are always a bit scary. It's a very thin duodenal wall that you're dealing with. I'm always quite generous then with the sub-polyp infiltration and lift. You can see here it went quite nicely, but I think the snaring here of a large polyp, that's a bit something, takes a bit of caution, and I would consider doing that under a general anesthetic to be safe. But this tiny one you can see went well, no big issues there. So the way I remember adenomatous polyps, remember pinky in the brain, solitary, out for world domination, remove them before it's too late, and they look like a brain that someone stepped on. So to quickly conclude the 3 most common types, if you go down, you do a scope, you suddenly see a polyp, biopsy, or if you're comfortable and it's an easy one, do your polypectomy at that same setting. Reminder, hyperplastic polyps will be the ones that you need to look for an association with H. pylori, and you should take all out that are bigger than 10 millimeters due to the potential for malignancy. And remember, they are associated with pre-neoplasia of the surrounding mucosa. So make an effort to biopsy there. Fundic gland polyps, by far the most common group. You can biopsy, and then once you've confirmed, you can discharge that patient. Only resect them or make an effort to get them out if there's an ulceration, or definitely if they are bigger than 10 millimeters. As I said to you earlier, there's you can decide whether you want to stop PPIs if there are multiple little polyps. I don't think that's necessary at all. However, if you look up retroflex and you see an absolute carpet of giant polyps, please be aware that you need to look for a syndromic association. Then the adenomatous polyps, the smallest group, but by far the most concerning group. You must resect due to their neoplastic potential, and you go back and you have to continue surveillance. We're going to talk now a little bit about some of the more common other polyps that you might come across and what to do with them. Firstly, I don't think we get about 2 or 3 a year. Vanix tumors, they're called. They're actually inflammatory fibroid polyps. And what's quite significant here is their size. They're usually quite chunky. And although they majority of the time occur in the antrum or the pylorus, they're usually quite incidental in their pickup. It's not often that there's a presenting issue that's brought the patient to your endoscopy suite. If you look at them microscopically, there's a massive eosinophilic infiltrative process. Why? Nobody really knows. There is no report in the literature of these things becoming malignant. So take it out, then you know what it is, because the mucosa that you biopsy is usually normal, so you do need to take out the whole thing. But there's no need for ongoing surveillance. I just want to show you one of ours that we did. This is actually a lady that came to us with intermittent kind of obstructive symptoms postprandially. She presented with pain postprandially, which resolved. And I don't unfortunately have a video, but it was a beautiful, clearly visible intersuscepting polyp. Sits a bit further away from the pyloric channel, but a jolly big chunky thing. And we only actually appreciated how big it was once we took it off. But you can see, again, process as always, we injected the base and had 2 little spots that we were a bit concerned about as regards bleeding, put 2 clips on, and then snared and took the whole thing out. And that's me holding it, and you can see just by the comparison, that's about 4 centimeters. Quite a chunky thing. Now, had I known or been able to judge that more accurately, my fault, I would probably have done this under a proper anesthetic, because my concern is when you are pulling these big things out through the esophagus, should your patient be not so sedated and retch against that, I think pulling anything big out, you can potentially cause an injury to the esophagus. So this is something I would, in retrospect, had I known, done under a general anesthetic. Then let's get to some of the more common syndromic polyps. You may come across patients presenting with juvenile polyposis syndrome. Remember that these are Hypertomatous polyps. They can occur pretty much everywhere, but very rare in the stomach. They're usually solitary, often quite small. Sometimes you can get a slightly bigger one, and they usually sit in the antrum. There is reports, or makes sense that they have a dysplasia risk, but there aren't really clear guidelines as what to do with them. Everyone just says remove them, but as to size, when not really clear. And unfortunately, they are quite similar in appearance to hyperplastic polyps. So here's a very clear image of quite a largish solitary polyp. Now that needs removal purely for size. But I think if you have a syndromic situation, my practice is to take out as many of the polyps as possible and as is safe. You may differ and decide to individualize, but I would take out juvenile polyps, although there isn't a clear indication as regards when, if you're looking at the size. Similarly, Poitiers polyps, again, Adenomatous polyps, again, anywhere in the GIT, usually, however, in the small bowel, but quite a big proportion may actually have gastric polyps, again, probably asymptomatic. Usually they are quite small. Again, a small malignant potential. Again, no clear guidelines, but for me, again, simply anything that's bigger than 10 millimeters, I would remove. But if there's a background of a syndromic situation and there's a couple only, I would try and get them all out. FAP on the other side, this is just a quick view of a duodenum. As you know, FAP, the duodenum is the second most common site, and they usually appear sort of 15 years after your colonic polyps, and very frequently, 30 to 70% of patients. And remember, this is important to look for, in that it's the second leading cause of death, unfortunately, in FAP patients. And I do think is sometimes a little bit underestimated and forgotten. You must go down to D3, as they sit in the D2, D3 area. Looking just at D1 isn't going to help you at all. It's a common question in the exams, and I also think you do need to know about it, in that it helps you to plan going forwards. Remember the Spiegelman classification for duodenal polyposis. So the number of polyps, the size, of course, the histology and the dysplasia grade. And that will help you to plan going forward. What do you do? Now, that video I showed you just now showed you, I don't know, 30, 40 small, very flat little adenomatous polyps sitting there. And what do you do with that? Difficult to answer. There's no way you can resect that, and that is not a surgical resection need at all. So if there's something big, something raised, we'll go for that one. What we've done in this situation, we don't have cryotherapy or photodynamic therapy. I don't think anybody has here. But APC, yeah, we do it. I'm going to say we do it, but I can't tell you that we always have a great success. There's often very little change, and I think the APC is sometimes just for my peace of mind. I don't think it does. You know, sometimes we see a great improvement, but I think 50% of the time we see no difference at all. So do you do it, or do you just continue surveilling and biopsy? Tricky. So these small ones, you can't biopsy them all. So focus your biopsies on those that look suspicious. And remember also with the duodenal FAP patients, you must do a side viewing scope. You do need to biopsy the ampulla, because that can be a spot where things rear their nasty heads. Now, this video is just something that comes across quite frequently. And what you see here is a little dimpled, almost donut-shaped polyp, for lack of a better word. And this one is in the classic position. It is sitting in the sort of antrum or distal gastric body, more antral side on the greater curvature. And this you do not need to biopsy, you do not need to resect. Remember this picture, this is a classic pancreatic remnant. It's completely benign. It's a normal embryonic variant, and it's quite common, about 1 in 1,000 patients. So if you're doing numerous lists, I guarantee you will come across a few of these. They look pretty, don't get excited, don't biopsy, don't do anything. It's not a guest. It's got a beautiful, innocent little umbilication, not like a guest. If you see like and vascular red polyps that are even present in the duodenum. Now, those are Kaposi sarcomas, and you do not need to resect. You also cannot resect them. I wouldn't advocate. It's going to bleed like mad. Just confirm with the biopsy. You do need that for your oncology colleagues to initiate their chemo, but don't remove these. These are, yeah, super vascular, but they are obviously fairly encountered fairly often in our environment. So, mistakes to avoid with gastric polyps, just a couple of things. Remember that you have, if you're doing a quick scope, you have inadequate gastric mucosal inspection, basically blind spots. I'm going to show you a mistake I made just now. So make sure that you're doing your retroflexion nicely, that you've got good insufflation, that you're seeing your D1 when you come out, and that you're looking specifically at your cardia 360 degrees. Be aware of your mucosal patterns and the morphology of the polyps. So get that language right so that you can explain on an endoscopy form quite accurately what it looks like, and the next endoscopist has an idea what's going on. The other mistake is to perform inadequate biopsies. So if there's a solitary polyp, make sure you do a biopsy, because that's not normal. If it's amenable to a polypectomy, by all means, go ahead. If you have multiple polyps, take a careful look at all of them. Don't just assume they're all the same, and make sure that you've got representative biopsies of not just one, but a couple. And then, as we said, for some conditions, specifically now the hyperplastics, you do need to look at the surrounding mucosa for an association with the H. pylori, past or present. Size matters, remember, anything more than 10 millimeters must come out. And we mentioned already, you're checking for H. pylori. Don't forget to perform a surveillance endoscopy for adenomas, even if you've resected it completely and you're quite impressed with your EMR or your ESD. Don't forget the polyposis syndromes, especially the one for the stomach, when you are retroflexed and you see this carpet of polyps. There's something going on. And then synchronous lesions. And this is where I'm going to show you something I did wrong. It's not the best image, and I apologize, but here you see me retroflexing in a gentleman who's been a few years, but I think he must have been late 50s at the time, long history of reflux, and you can see why. He's got a small sliding hiatus hernia there, PPIs on at least 2 to 3 decades at the time, I think. And you can see there are a couple of unexciting little polyps, and previous biopsies had confirmed those to be Fundic gland polyps. There is an associated gastritis, so it's all a bit red and unhappy. And then slightly deeper view, still retroflexed. And this is where I made my mistake, because this is the third time I think that I only picked it up. Look here, just behind my scope, there's a more flat, unhappy looking polyp, not looking the same, much larger. And And on subsequent biopsies, I'm not sure if you can appreciate this over your screens, but look at the diameter of my scope. This thing is at least 2 to 3 centimeters. So this is definitely not a fundic gland polyp. I biopsied both sides. That came back as an adenomatous polyp. And unfortunately, as you can see here in retrospect, that was clearly an alarm bell. That is already an infiltrative adenocele. So here's a patient with 2 types of polyps, and that was the second scope that I only picked it up on. That's because I just rushed through it. Perhaps it was in my blind spot, but that's already a mistake. And second mistake is to forget about the possibility of synchronous polyps happening. So that's a very brief overview from my side of sort of more practical aspects of common polyps that you encounter on your average endoscopy list. And I hope you specifically remember the 3 most common ones, and perhaps the mnemonics to try and remember some of the aspects thereof. Thank you for your time.
Thanks very much, Galya. I really appreciate that very practical talk, especially coming from a surgical endoscopist, because surgeons know the 3 common things in the correct order. Physicians know 20 in random order. So it is important to remember the others because you will come across them. But I think you gave them an excellent working algorithm for managing these. There's a couple of questions in the chat. One is to do with the hyperplastic polyps, and what should your biopsy protocol be for the surrounding mucosa? What should you actually do?
So first of all, remembering to do it. I think that's number 1. And then you should be biopsying according to the Sydney protocol. That would be my approach to that. So remember to do it is number 1. And when you do it, don't just randomly biopsy, do it properly.
And obviously you've pointed out the pitfalls of portal hypertensive gastropathy. How do you avoid falling in the trap of biopsying some of these things? Because sometimes they don't look quite so vascular as you find out when you actually try and touch them or do something to them. So what's your approach to those? Again, especially if it's an incidental scope where you really don't know the patient's got portal hypertension.
Yeah, I think that's a fair question to ask. I think most of the time you should have an idea that you are scoping someone with portal hypertension. Not always, fair. When you come down into your stomach, look at your mucosa real close. Portal hypertensive gastropathy, the mucosa looks like cobblestones. It looks almost edematous, and that cobblestoney appearance is to me quite a clear concern always if I see that this is going to be a vascular biopsy if I take a bite out of it. Yeah, tricky whether you should be biopsying, because sometimes you're also worried about as an associated gastritis. So I think yeah, there's nothing wrong with taking 1 or 2 bites. Yes, it might bleed a bit. You can always cauterize that. The ones that I would be very cautious of is by far those polyps associated with that, and you can see the effects of that. So I'd be cautious of that. Rather treat your underlying portal hypertension before you go hacking out numerous polyps there. 1 or 2 bites to confirm whether there's an inflammatory background, I think is not wrong, and that is not going to be torrential bleeding.
Thanks. And then the other thing was about adenomatous polyps. How often and how long should you follow them up if you've removed them completely?
Okay. First of all, may I just add, if I haven't removed them completely, how long do you wait? It's to me similar in approach. If I've taken out a high-grade dysplastic segment of Barrett's and it's incomplete, I generally wait for 6 weeks. And then I go back. By that time, the scar tissue, the fibrosis, the healing is complete, and you can go safely back and lift and try and get out what you can. So if I've got an incomplete resection of an adenoma, I wait 6 weeks. I don't wait until 6 months. I go back after 6 weeks. If you've got a complete resection and you've got a low grade dysplasia, the recommendations is that you can go back following a complete resection annually. I think that's fair. However, if there's any element or spot of high grade dysplasia, you should be going back after 6 months. And remember, as I said during the talk, even with a complete low grade, very happy polyp, and you did a good job, these things come back in a small proportion. So don't forget about this patient. This patient deserves an annual surveillance endoscopy regardless.
Can I ask you one thing about the trend now, especially is towards doing not the very quick gastroscopy, but to also inspecting the stomach and recognizing landmarks. What's your feeling on routine photo documentation of the stomach? And again, it comes back to your business of mapping where these polyps and might be. Is it time to move to routine photo documentation, and even in these very prolific or slightly atypical polyps, to take video of them rather than start messing around with them?
Absolutely. I'm a huge fan and would, if possible, advocate for that at all times. What we are doing in our setup is of all malignancies, of all concerning polyps and big ulcers, we take a routine video, which we then attach to that patient's folder. On the other hand, I work in private as well, where that is not possible, strangely enough. It's easier to do in our setting here at Grooteskier, but in private, I take photos of every landmark of my scope, even my normal scope. I think it's a fantastic opportunity to go back sometimes a year later and just compare. So yes, in my practice, it's something I do routinely. Yeah.
Thanks. Are there anybody else would like to make some comments, and would anybody like to unmute and show us their video? I think we've now got 50 people on the call, so that's a very good attendance, and we hope you've enjoyed it. But do you have any further comments? I think exhausted the chat comments. Or has Galya answered all your queries?
The one thing I didn't go into at all, and that was quite specifically with intent, was GNets. As we have a talk on that, Prof, if you're interested in the future, I think that's a talk on its own that we can give another day. So I can specifically show those.
I think that's a very interesting thing you talk about, because we think of polyps as mucosal lesions, but often these submucosal lesions are just as problematic, and in fact, some ways more problematic. So, and I think they are better dealt with in a forum, but they can be quite confusing and not look too dissimilar to some polyps when you see them for the first time, if you're unaware of them. So we look forward to a GNet talk. I'm fed up with hearing about PNETs, so GNet sounds quite good.
There's a question there: how do we mark small polyp margins for the pathologist? The truth is, I don't. Very small things, I don't. Yeah, I think if it's sort of getting to 15-20 millimeters, you can pin them down on a piece of paper or something, but anything less than a centimeter, I confess I don't. And yeah,
generally with these adenomatous polyps, obviously the Japanese have a great deal of experience with ESD. How many ESDs are you sort of doing a year? And what's your, if you get one of these flat Paris classification polyps, what's your approach to them? Which ones do you do ESD, and which ones do you do with a snare?
That's easy to answer. Depends on size and position. So I think if they are small and they're going to fit nicely into my snare or my polyp you know, we tend to suck them up and put a polyp, a snare around it, then I would go with an EMR. I think it's safer, it's quicker. Excuse me. As regards the position, I think you'll all agree with me, a D2 ESD, you need some hair on your teeth to take that on. Those duodenal walls are so thin. Of all the ESDs I've done, the ones I've perforated most often as regards position have been in D2. D1 you can still get away with, and I think there it depends very much on the positioning. The other position I would not approach with an ESD is very tricky, sort of on the cardia as you retroflex. ESD on retroflexion, gosh, that's for me anyway, quite a nightmare. So I would always approach an ESD where I can offer some certainty as regards that I'm actually going to do it safely, to be very honest. And that gastric body antrum is sort of my favorite spot. And obviously the distal esophagus is quite approachable. But D2 and on retroflexion in the cardia, no, I would definitely always do an EMR.
Thank you. That's a really nice practical step to end on. And I thank you very much for your insight, and it's really, I think we've informed the audience. So it's up to me just to wrap up the meeting. Remember, this is recorded, and you can find it on the Gastro Foundation website. I'm not sure exactly how quickly it will be there, but certainly within the next week, I would imagine. Obviously, thanks to Galya, and also to the iEcho team, both iEcho India and Mexico. Remember that we can't do this without the sponsors who help us put this together and help us run it, and to the girls, Karen and Cheryl, who really keep us in order and keep us on track. Next week, I believe, is pediatrics, so I hope you're all going to attend that, and have a good 2024. Thank you.